When you think about a standard surgical procedure, there's this underlying assumption of predictability for you as a patient. It's a bit like carpentry.
Right. You cut a piece of wood, put a screw in it, and the wood holds the screw.
Exactly. The material behaves exactly the way you expect it to. But when you introduce a connective tissue disorder, specifically Ehlers-Danlos syndrome, or EDS, that solid piece of wood you thought you were working with suddenly behaves more like wet cardboard.
Yeah, the tension causes tears. The screw just refuses to hold right out of the gate.
And the fundamental rules of surgical construction just completely fall apart.
It forces a total rewrite of the surgical playbook. I mean, the mechanical principles of the human body, for the vast majority of us, are remarkably consistent.
Tissues hold sutures under tension.
Right. Incisions close on a predictable timeline, scars form and bind structures together. But in EDS, every single one of those assumptions is compromised at a cellular level.
Which brings us to the core of what we are pulling apart for you today. We've got this massive stack of medical journals, specialized clinic insights, and surgical guidelines on the table today.
And we're drawing from the NHS, NICE, and some incredibly detailed data from OAE Publishing.
Yeah, and our mission today is to answer a highly specific, honestly high-stakes medical question. Does poor wound healing in EDS affect surgical tightening procedures like pelvic organ prolapse repairs or vaginoplasty?
But, to even approach that question, we have to strip away the pop culture understanding of EDS.
Absolutely.
When people hear Ehlers-Danlos, they tend to picture, party tricks, stretchy skin, being double-jointed.
Right, the hypermobility stuff.
Exactly. But focusing on the hypermobility completely misses the systemic reality of the condition. We are talking about a fundamental alteration in the building blocks of the human body.
Turning what should be a routine day in the operating room into an incredibly volatile physiological puzzle. Okay, let's unpack this. Because before we can even begin to examine how a patient with EDS heals from the trauma of a scalpel, we really have to look at why they're showing up in the surgical ward at rates that just completely dwarf the general population.
And that comes down to the architecture of the pelvic floor.
It really does. So let's look at HEDS, the hypermobile subtype, which is the variant we see most frequently in these surgical contexts.
Yeah, it's an inherited connective tissue disorder where collagen is produced incorrectly.
And collagen is the most abundant protein in your body. It's the glue holding everything in place.
Right. And we tend to think of the pelvic floor purely in terms of muscle, like a muscular hammock. But the integrity of that hammock actually relies heavily on specialized connective tissues.
Like the uterosacral ligaments or the endopelvic fascia.
Those are the heavy lifters. I mean, the ligaments suspend the internal organs from the skeletal structure, and the fascia forms a dense, supportive scaffolding around the vagina, bladder, and rectum.
So in a typical patient, that collagen network is firm but responsive.
What's fascinating here is that in an EDS patient, that structural collagen is fundamentally defective. It's overly elastic. And more importantly, it lacks resilience. Once it stretches, it just fails to recoil.
It makes me think of building a house with faulty mortar. No matter how strong the bricks are, like the mortar, the collagen is stretchy and weak, the walls are eventually going to sag.
That's a great way to look at it. And the clinical data reflects that structural failure with terrifying clarity.
Yeah, let's talk about that survey.
Right. So a comprehensive survey of 1,300 women with HEDS revealed a 21% rate of pelvic organ prolapse, or POP.
21%. To put that in perspective for you listening, the symptomatic rate in the general population hovers around 3 to 8%.
It's an astronomical jump. And the crazy thing is, it's happening significantly earlier in life.
We are seeing EDS patients developing severe, life-altering prolapse in their late 20s or early 30s.
Completely absent of the typical mechanical risk factors. No multiple vaginal childbirths, no obesity, no menopausal estrogen drops.
Wow. So the tissue simply gives out under the standard pressure of gravity and daily living.
Exactly.
So the very structural failure that causes the organs to drop in the first place is exactly what makes fixing it so dangerous. I mean, if the native tissue is so unreliable, my instinct would be to bypass it entirely.
You'd think so, right?
Yeah, you don't try to stitch up faulty mortar. You bring in something artificial to hold everything up, like a synthetic mesh.
And that actually was the medical consensus for a long time. In standard prolapse repairs, surgeons frequently perform an infracoccygeal sacropexy.
That's the procedure where, instead of just lifting the surrounding tissue, they anchor the top of the vaginal vault directly to the sturdy ligaments near the tailbone.
Right, using a synthetic mesh tape. It acts as a permanent artificial sling. But Introducing mesh into an EDS patient creates a catastrophic new variable.
because you are placing a rigid synthetic material against incredibly fragile, easily damaged biological tissue.
Exactly the problem. The sources highlight a significantly higher risk of mesh erosion in the EDS population.
So over time, the constant microfriction of that rigid synthetic tape against the defective collagen causes issues.
Oh, massive issues. It causes the tape to literally saw through the vaginal wall or erode into adjacent organs like the bladder.
Which triggers severe chronic pain, massive infection risks, and necessitates highly complex, dangerous surgeries just to extract the embedded mesh.
Right. Which means surgeons are often forced back to relying on the patient's native tissue. They go in, physically remove the excess stretched out mucosa, and stitch the separated muscle fibers and connective tissues back together.
They try to literally pull the biological hammock tight again. But wait, if the fundamental genetic code of their connective tissue says I am stretchy and weak, won't any soft tissue repair just stretch right back out?
It's a very valid concern.
I mean, are we just buying them a temporary illusion before gravity wins again?
That pushback gets right to the heart of why the medical establishment has historically abandoned these patients. Surgeries that rely only on soft tissue repair in EDS have a notoriously high recurrence rate.
The tissue just stretches out again.
Yeah. But beyond long-term failure, surgeons are terrified of the immediate perioperative risks. The tissue is remarkably friable. It tears under minor handling.
And that leads to wound dehiscence.
Yes. Dehiscence is where the wound bursts open because the sutures rip completely through the fragile tissue under tension.
Think of a tight wire pulling through a block of soft cheese.
It's exactly like that. Add in a massive increase in bleeding tendencies because the collagen lining the patient's blood vessel walls is equally faulty.
Plus, a severely delayed healing timeline. You can see why the standard operating procedure for decades was simply to deny care. Surgeons viewed surgical tightening in EDS as a guaranteed failure.
Okay, they just wouldn't do it.
But if you're looking at the actual clinical outcome data, an entirely different, completely counterintuitive story emerges. Here's where it gets really interesting. Let's look at the retrospective case control study from OAE Publishing.
That study completely flips the script on surgical risk.
It really does. They looked at gender-affirming surgery, specifically vaginoplasty, which requires extensive tissue dissection, repositioning, and complex wound healing under tension.
And they reviewed an enormous cohort, over 1,300 patients. Out of those, 36 had a documented Ehlers-Danlos diagnosis.
And they matched those 36 patients with a tightly controlled group of non-EDS patients to track and compare their postoperative complications directly.
Now, based on everything we just discussed about tissue friability and dehiscence, you assume the EDS group would have a disastrous complication rate.
Totally. But major complications, meaning massive bleeding or structural failures that required the patient to be rushed back into the operating room, were virtually identical.
It was 2.8% in the EDS group versus 5.4% in the non-EDS control group. Statistically, there was no significant difference.
Which is already a paradigm-shifting revelation. But the data goes even further. This is the most shocking statistic in the entire stack of research.
Yeah, I know exactly what you're going to say.
When the researchers looked at wound healing issues of any severity, minor separations, delayed closures, minor infections, the rate was actually lower in the EDS group.
It's incredible.
Only 28% of the EDS patients experienced wound healing issues, compared to a massive 47% in the non-EDS control group. Wait, really? Lower.
It's a stunning finding, and if you cross-reference the literature, it's not an isolated anomaly either.
Right. The sources pull in an animal study examining dogs and cats with EDS-like connective tissue dysplasia undergoing surgery,
as well as a pediatric study tracking 279 spine surgeries. Neither of those distinct studies found significant differences in wound complications compared to non-EDS peers.
If you are looking at this data, your first thought has to be, how is this medically possible? The underlying biology dictates that their tissue should physically fall apart under the stress of a scalpel.
Right.
Yet the data shows they heal better, or at least equally as well, as someone with structurally perfect collagen. It feels like the data is openly contradicting the biology.
It does seem paradoxical until you zoom out. If we connect this to the bigger picture, we must first distinguish between the subtypes.
Okay.
Vascular EDS, or VEDS, carries severe spontaneous arterial rupture risks. Those patients face life-threatening surgical realities, but the patients in the gender-affirming surgery study almost certainly had hypermobile EDS.
And the key variable driving these successful outcomes wasn't a sudden improvement in the patient's collagen, was it?
Not at all. The critical variable was the surgeon.
Huh. The surgical team knew they were operating on an EDS patient beforehand. The diagnosis was right there on the chart.
That changes everything. Because these patients had an established diagnosis prior to stepping into the OR, they were managed with extreme hypervigilant surgical care.
They didn't receive standard protocols.
Exactly. The surgeons anticipated the biological failures and altered their entire approach to bypass them. The data suggests that the historic paradigm of universally denying care is actually a massive overcorrection.
Because the non-EDS patients in that study likely received standard routine care,
Bro.
which resulted in a 47% minor complication rate.
While the EDS patients got the absolute highest tier of meticulous, customized surgical intervention.
So the surgical technique actually overrode the genetic biology. That leads us directly to the blueprint. Since the data proves that successful lasting surgical tightening is absolutely possible for EDS patients, how exactly are these hypervigilant surgeons adapting their techniques?
What is happening in that operating room to prevent the wire from cutting through the cheese? Well, it begins with intraoperative tissue handling. You cannot use standard retractors or pull EDS tissue to visualize the surgical field. It requires incredibly gentle, slow manipulation.
But the real adaptation happens during the wound closure, doesn't it?
It does. Surgeons must utilize a multi-layered closure technique. Instead of just stitching the surface skin and a single underlying layer, they meticulously stitch multiple deep layers of tissue.
So by distributing the mechanical tension across 4 or 5 different depths of fascia and mucosa, they dramatically reduce the pulling force on any single point.
Exactly, especially the fragile surface skin.
And they have to completely abandon certain tools. The guidelines are adamant: avoid surgical staples entirely.
Because staples rigidly pinch and cut into fragile skin, they create localized necrosis.
So instead, surgeons rely on subcuticular stitches, sutures, buried just under the skin layer, and then reinforce the surface with heavy Steri-strips.
And the timing of those supports is completely altered. A normal patient might have sutures removed in a week. Because of the delayed healing cascade in EDS, surgeons leave these supports in place much longer.
Removing sutures at least 5 to 7 days later than standard protocol.
Yeah, you are physically forcing the wound edges together for an extended period because that faulty collagen needs significantly more time to weave its weakened fibers together into a stable scar.
It's like the difference between tailoring a sturdy denim jacket and tailoring a delicate silk dress.
Oh, that's a brilliant comparison.
Thanks. With the denim, the fabric itself absorbs the tension. You can use heavy needles, thick thread, and pull the seams tight, and the denim will just hold. But with EDS tissue, it's like wet silk. The material has almost no internal resistance.
Right. If you pull a thick thread tight, the force isn't absorbed by the fabric.
It's concentrated entirely on the microscopic point of the needle hole, carrying it to shreds. You need finer needles, a multi-layered distribution of force, and a complete lack of pulling tension to make the seams hold.
That captures the physics of it perfectly. And to assist that silken healing, surgeons bring in specialized biological materials. The guidelines specifically highlight collagen wound dressings, like Fibricol.
How does that actually work at a cellular level? Does it just cover the wound?
It's much more active than that. Fibricol is a biocompatible matrix made of collagen and alginate. When applied to fragile or necrotized EDS tissue, it provides a physical, three-dimensional scaffold.
It essentially tricks the body's fibroblasts, the cells responsible for healing, into migrating across the wound bed faster than they naturally would.
Yes, it aggressively kickstarts a sluggish healing environment. Additionally, to address your earlier concern about the tissue just stretching back out under the weight of the organs, surgeons frequently use localized, biological, or highly specific mesh overlay grafts.
But not as standalone tension slings that cause erosion, right?
Exactly. They use them as flat, musculofascial supports sewn over the repair to absorb the mechanical weight, taking the tension off the native skin sutures entirely.
Okay, so let's say the surgeon executes this flawlessly. The multi-layered closure is perfect, the Fibricol is applied, the tension is distributed. Are they in the clear? Or does the body's internal plumbing still pose a threat once they leave the OR?
Oh, the internal plumbing is arguably the biggest threat to the repair. Treating an EDS patient requires treating the entire systemic cascade of the disorder.
For instance, EDS patients frequently suffer from severe gastrointestinal dysmotility.
Right, because the GI tract relies on connective tissue to physically perform peristalsis, the muscle contractions that move food through the system.
Precisely. The faulty collagen means the digestive tract moves incredibly slowly. Add in post-operative opioid painkillers, and you have profound constipation.
And if a patient experiences constipation and begins aggressively straining in the bathroom a week after a pelvic floor prolapse repair,
The downward mechanical force can instantly blow through those delicate, multi-layered sutures.
it ruins the surgical work in seconds. Aggressive bowel management, usually heavily coordinated with a gastroenterologist, isn't just a comfort measure. It is a critical component of surgical survival.
I noticed the guidelines also flag significant issues with anesthesia. It's not just about putting them to sleep.
The interaction with local anesthetics is fascinating and dangerous. Many ATDS patients have a documented genetic resistance to local anesthetics like lidocaine.
Wait, the pain blockers just fail.
Yes.
Yeah.
The leading theory is that the altered connective tissue matrix physically prevents the anesthetic from binding to the sodium channels in the nerves.
Wow. So if the pain management team treats them like a standard patient, that EDS patient is going to wake up from a complex reconstructive surgery in agonizing, unmitigated pain,
And a sudden spike in excruciating pain causes a massive spike in blood pressure.
which immediately triggers the other EDS risk factor, bleeding. The increased arterial pressure blows out the fragile blood vessels at the surgical site, leading to massive hematomas that require rushing the patient back into surgery.
It is a terrifying domino effect that can only be prevented by anticipating the anesthetic resistance and utilizing highly customized, multimodal pain blocks.
What about physical therapy? If the soft tissue is this fragile and you've just spent hours delicately sewing it together, my instinct would be to aggressively bulk up the surrounding muscles to compensate.
You'd want to build a muscular fortress around the weak connective tissue.
Right. Can't they just hit physical therapy hard to do that?
That is the exact opposite of what you want to do, and it's a very common post-op mistake.
Really?
Yeah. Standard, aggressive range of motion physical therapy relies on forcefully stretching and tearing muscle fibers to rebuild them stronger.
Oh, I see. In an EDS patient, that forceful stretching transfers sheer mechanical stress directly to the newly repaired, highly fragile surgical site.
It will stretch the repair right back out.
Mhm.
Rehabilitation must completely avoid aggressive strengthening. The focus shifts entirely to joint stability, proprioception, and incredibly precise, controlled muscle coordination without ever overextending the surgical boundaries.
So to bring this all back to our central mission for you today, does poor wound healing and fragile tissue in Ehlers-Danlos syndrome fundamentally affect surgical tightening procedures like prolapse repairs? Absolutely.
It turns a standard mechanical fix into a highly volatile biological minefield.
The tissues are inherently weaker, the risk of explosive wound dehiscence is dramatically higher, the bleeding risks are elevated, and the healing timeline is stretched to its absolute limits.
But the crucial takeaway from this deep dive is that it does not make these life-improving surgeries impossible.
Not at all. The clinical outcome data strongly proves that when you combine hypervigilant surgical techniques like multi-layered closures and delayed suture removal with a customized full-system approach to post-op care that anticipates things like GI dysmotility and anesthetic resistance, EDS patients can absolutely achieve successful, lasting reconstructive repairs.
A connective tissue disorder is no longer an automatic disqualifier for specialized care.
So what does this all mean for you? Throughout this entire analysis, we have been talking about mechanical workarounds for a deeply biological problem. We're discussing tension distribution, fibrocol matrices, and subcuticular stitches.
This raises an important question, though. If the fundamental issue is that the cellular mortar is inherently weak, what if the future of pelvic floor repair in EDS isn't mechanical at all?
That is exactly where the cutting edge of connective tissue research is heading. The sources briefly touch on emerging therapies that aim to fundamentally alter the tissue environment before the scalpel ever touches the skin.
We're looking at the application of targeted mast cell stabilizers and platelet-rich plasma, or PRP.
How do mast cells tie into surgical healing?
Well, mast cells are immune cells that regulate inflammation. When they trigger, they degranulate, releasing a flood of histamines and enzymes, including tryptase, into the surrounding tissue.
And in many EDS patients, these mast cells are hyperactive. They are essentially bathing the already defective collagen in localized enzymes that break it down even further.
Right. By utilizing targeted mast cell stabilizers, you halt that localized chemical breakdown. You stop the biological wrecking ball.
and then you combine that with PRP to rebuild.
Exactly. PRP involves extracting a high concentration of the patient's own cellular growth factors and injecting them directly into the weakened pelvic floor tissues.
The provocative question we are moving toward is this. What if the future of vaginoplasty and prolapse repair in EDS isn't about inventing a gentler surgical technique?
What if it's about utilizing biological therapies to fundamentally precondition, regenerate, and cellularly strengthen the patient's connective tissue months before the surgery even begins?
Changing the mortar before you ever try to rebuild the wall. That is an incredible thought to leave you with as we wrap up today's analysis. Thank you for joining us on this deep dive into the fascinating intersection of EDS and surgical healing. Keep exploring the data, keep asking the difficult questions, and we will catch you on the next one.